Good afternoon, ladies and gentlemen. Welcome to this lunchtime symposium supported by Hitachi, entitled Diverse and Innovative Imaging Solutions, Creating New Value Through Innovation and Digital Technology. This lunchtime symposium, which has lunch attached to it, as you've already collected all your lunches, will have three speakers this afternoon. Three very good speakers, well recognized and well respected in their individual fields, who will give you an overview of the new techniques that are coming through and how they'll be used in clinical practice. Each of the speakers will stop after their speech and give you some time to ask any questions, should you have any, and they will remain for a few minutes at the end of the session should you want to ask them any individual questions. It's my great pleasure to invite the first speaker up to the podium, Professor Jean-Michel Correaz from Paris, who I've known for many, many years now, and I'm absolutely sure this is going to be a very good lecture on the clinical usefulness of new fusion imaging for interventional kidney procedures. JM, please.
Thank you very much. Ladies and gentlemen, it's my pleasure to be here, and I would like to thank you very much, the Hitachi group, for the opportunity to develop that collaboration and start working with these new technologies. So basically, in the renal field, we see more and more procedures, including ultrasound-guided biopsies, percutaneous nephrostomy, drainage, and minimally invasive ablation of renal tumors, because we're facing a very strange situation. We see more and more of small tumors, mainly because of the wide use of imaging, but we simultaneously see the increased incidence of the renal lesions in the elderly population, the increasing incidence of chronic kidney disease, and urologists demonstrated the efficacy of ablation. The guidance is, of course, the key of these, the development of these procedures. Lesion identification and vascular relationships are taking advantage of ultrasound techniques combining B-mode and color Doppler ultrasound, visualization of needle track and tip, and, of course, fusion imaging. And the very specific attention that I would like you to focus on is the use of automatic tracker that really improved the situation. Of course, we all know that major ultrasound advantage are true real-time imaging techniques, and this is a patient with a suspicion of a sarcoma of the inferior vena cava. High spatial and contrast resolution, large availability, it's a non-toxic and mobile technique, and Doppler ultrasound can be used for vessel identification, and we know that here the renal artery and the renal vein should be crossing very close. We can also give a contrast agent to improve the detection of the vascularity of the lesion and the detection of the main vessel that we would like to avoid. Of course, then guiding the electrode or the biopsy needle inside the lesion with such a long track is not easy, but look at what we can achieve when we have available a good imaging technique. Of course, this technique is facing some limitation, including lesion identification, difficult needle track imaging, in particularly in obese patients after surgery, loss in imaging quality after surgery or biopsy, and limited evaluation of surrounding specific structures such as the bowel. Of course, there's no exclusion of the techniques, and in some cases, CT has a clear advantage, including high spatial and contrast resolution, needle track visualization, limited operator dependency, but is also facing limitation, and this is not a real-time imaging technique, and you know, despite fluoroscopy that we are mainly using intermittent acquisitions, iodinated contrast media that has some kind of toxicity, time-consuming, metallic artifacts, limited availability, cost, and radiation exposure. So this is just a case that just demonstrates the value of ultrasound. This is a lady that had operated left kidney papillary cancer a few years ago, and then that was the papillary cancer. And then a new lesion is rising and growing very fast, about 10 millimeters in 2 years. She has severe claustrophobia. And then we see here the ultrasound Doppler examination. The lesion is here, slightly hypoechoic. And then we give the contrast. And the combination of contrast-enhanced ultrasound with this identification of the lesion, you see enhancement in the cortex, enhancement in the medulla, and you see that this lesion is not enhancing. So we did MRI examination under severe sedation, and so now we are sure that this is not a new renal papillary cancer, and this is just a typical hemorrhagic cyst. So really changing the diagnosis based on the evaluation of ultrasound is a key approach. And this is a very similar case where the lesion was not obvious at CT, despite the injection of iodinated contrast media, that we saw no vessel with the color Doppler imaging. And is this a normal kidney, or is this a hypertrophic parenchyma? Or is this a renal tumor? And you see that the enhancement in the lesion is not so homogeneous than in the surrounding cortex. Basically, we did the biopsy, and there was a chromophobic cancer. So the real additional value of ultrasound is very clear, including contrast-enhanced ultrasound. But now, moving to fusion imaging, it's not a very new concept because it started more than 15 years ago with a combination of PET and CT or MRI, has been extended recently to ultrasound, but there are some clear challenges. However, the two techniques together has major new opportunities because ultrasound is bringing the real-time imaging, spatial resolution, and mobile technique, and the CT or MRI is bringing contrast resolution and overall evaluation to the surrounding organs. And so, and these are the technology that has been developed right now. But what kind of fusion imaging would you use? We have basically three techniques. The first one is doing registration or synchronization in a cognitive way. You look at very closely at the MR or the CT image, and then you move to the interventional room, and you use the ultrasound, and you try to reproduce the same image and find the same landmarks. Or you can use a software-based or software-assisted registration. This is what we call fusion, or the true fusion techniques. And you can use the anatomical markers. In the majority of cases, this is possible when you have a previously acquired data set. So you have these previously done CT or MRI, and you just fuse the information of the CT or the MR inside the ultrasound system, and then you can improve the detection and the visualization of the lesions. But you can also, and I think this is a major change, you can also use active patient tracker. So during the MR or during the CT examination, you put the tracker on the patient, and the tracker will be automatically recognized by the ultrasound system. And so the fusion will be very fast. There's no consensus about the best technique, but clearly, if you're starting to use these techniques, you will be totally convinced. So cognitive fusion imaging is still very much helpful because you have information from CT and MRI, and then you move to the CT screen, and then you look at the lesion, and then you go back, or you have inside the room, you have your CT screen, and then you can combine the advantage of the two techniques. But this is not real time, and this is, of course, with some severe, sometimes difference between the two images. However, it is simple, it's fast, there's no need for additional equipment, and it basically improved the performance of ultrasound-guided biopsies. However, and that's what we see in our routine practice, it requires a larger training and experience, and then there's a longer learning curve. So now we can combine the information of CT and MRI inside the ultrasound system, and then will be displayed all together. And this is kind of very exciting technique. And now we can upload up to 4 data sets that could be MR, CT, and will be combined with the ultrasound imaging. You can use the non-contrast enhanced CT and add the contrast enhanced CT on it. Then the electromagnetic field generator and sensors will be recognized by the system, and you'll have this kind of simultaneous display with the CT and ultrasound. Of course, this is additional technology, and you will have to learn exactly how to set and how to put the electromagnetic field generator and how to set these sensors around the ultrasound system or even on the patient tracker. So basically, if we look at the registration using anatomical markers, there is a spatial localization of the abdominal transducer by the electromagnetic sensor, and this is what we put on the sensor. And the registration is done by finding some similarity or identical anatomical structures between the CT and the ultrasound system. Using the active patient tracker, the volume data sets are acquired during the procedure with the tracker on place and automatically detected by the Arieta system, and automatic registration can be performed just by pushing the key, one key. So advantage of anatomical markers is what I said. So basically, it's this fast and procedure that doesn't need additional workstation or computer. But limitation is that it takes time, and the respiration, prop pressure, needle bending will be affecting the quality of the registration. It needs some additional training, of course, and the precision is getting better when you're getting close to the fusion plane where you did these fusion. The automatic tracker technique is something that is much simple because automatic registration is done by automatic recognition of the landmarks. It's very fast. It takes only a few seconds. Basically, you just press the body motion tracking, and it's very accurate. And this accuracy is maintained all over the planes and not only at the plane where you did the fusion. And basically what I think is very interesting is that we take advantage of the position of the patient, because when you turn the patient during the CT, and here we have a column, the left column attached to the renal tumor, you see that the overall anatomy inside the abdomen is changing. So really moving the patient is something that takes advantage of the position of the patient. This technique also has some limitation. First of all, you need to have a longer CT acquisition to cover the active patient tracker. You must use thinner slices. And of course, if you have new change in the anatomy, like dissection, because you inject some fluid inside the abdomen, or if you have a hematoma or any change in between the position, then of course you will have to upload the new acquisition. But this is very simple, and basically it takes very little. One of the key points, of course, is needle bending, and this is exactly what you see here. This is a very long track until reaching the tumor. And you see that by bending, I can improve and look precisely where is the tumor. Here I'm bending, so I'm not in trouble to look at the needle here because I'm bending it. And now I will just let the system go back to the initial position, and then I can further move the electrode inside the tumor for ablation. The active patient tracker requires a few tricks and tips for its position. So it should be positioned about some location that is not moving, not affected by the patient breathing. And also you should avoid to insert the cable before the initial CT scan, otherwise there are artifacts because the cable is metallic and you see these markers on the active tracker, and you should be distant from the electromagnetic generator from 20 to 50 centimeters. And here you see the active tracker is just there, and you see that we're not locating the electromagnetic generator too close from the CT scan. We also move the patient slightly above the metallic bed at the CT, because I think this is improving the comfort of the patient and also limiting the artifacts due to this huge amount of metal inside the bed. So we can optimize the entry point, we can optimize the needle track, and this is exactly what we're doing here, optimizing the entry point, finding the best one. And in this case, where we have the colon attached to the renal tumor, we're just moving to find exactly where we can put the needle. And this is the kind of results that we can get. Here we have a track, and you see that we have almost no space. But we will create the space and push the glucose inside the space to get the colon away and be able to treat the lesion. And this is pre-treatment and this is post-treatment without colon complications. Of course, in some cases, this technique is very helpful in this patient with a cystic renal tumor, cystic renal cell carcinoma. We can look at the lesion, move, optimize the position of the electrode and get the two electrodes inside the tumor. We can move and get a transverse view. This is longitudinal view. And then finally, we can ablate the lesion in a very safe situation, and this is the control after ablation. So really, these tools will become, I'm convinced, totally convinced, routine use in the very next future. But there are also new tools arriving, like needle tracking, and you saw how valuable can be needle tracking. And Hitachi also introduced a new technology to take into account bending of the electrode based on the detection of the needle track here during the biopsy or during the insertion of the electrode of the biopsy needle. So really, but in this case, you must use an attached system to get the very precise location of this needle track. Also, there's a 3D sim navigator that is very interesting because it provides information about the C-plane. And in this case, we can see the C-plane on the CT that is reconstructed. And you know that when we're doing difficult procedures, we must take into account very clearly the surrounding organs, like the pleura or the adrenal glands or the colon, or in some cases, the small bowel structures. So finally, I think that we have now new tools that provide help for difficult procedures, fusion imaging, needle tracking, 3D SIM navigator, and I didn't speak so much about the e-field simulator, and this is a technology that provides some information about the ablated or the future ablated area to be able to locate very precisely the electrodes. So altogether, these fusion techniques have definite advantage, and this is including optimization of the procedure and reducing the duration of the procedure. And we know that this is a key because we all perform procedures under a conscious sedation, so the patient is awake, so reducing the time of the procedure is very important. And of course, it has some cost and training. And I would like to thank you very much, the Hitachi team that helped us to get a larger experience on this technology. Thank you very much.
Thank you very much for that very comprehensive overview of the subject. Is there anyone in the audience that would like to ask a question? Please.
So the question is about motion. So is this about increasing the number of imaging?
Yeah.
Well, in these, basically we're dealing with cancer people, and they have multiple lesions in most of the cases. And so getting the best evaluation of the disease and being able to locate very precisely the needle, I think, is a key. So having a different view, each technique, each imaging technique is bringing a new vision of the lesion situation, number of lesions, characterization of the lesion, and also, vascularization of the lesion. So I don't think that they are competing. In fact, they're just getting together to help us to get the best vision of what's going on in the kidney.
Thank you. on a practical note, where do you do your procedures? Is it always in the CT room? Or do you put your ultrasound separate to do the fusion? Where is your base?
This is a good point. In fact, we realized almost 18 years ago that for renal tumor ablation, we always we always put the patient inside the CT room. But for biopsy, we do procedures inside the ultrasound room because we don't have the same constraint about precisions.
Okay. Thank you. Thank you very much, Michael.
Thank
you. We'll move on to our next speaker, who is Giovanna Ferraioli from Pavia in Italy, a wonderful city. If you haven't been there, I would encourage you to visit. And we're going to hear about the role of combi elasto and attenuation measurement in the assessment of diffuse liver disease. Giovanna.
Thank you. These are my disclosures. And for the assessment of liver fibrosis in patients with chronic liver disease is very important because liver fibrosis affects the management and the prognosis of these patients. And we know that fibrosis causes an increase of liver stiffness, and liver stiffness can be measured using the elastography techniques. And nowadays, the non-invasive method for the assessment of liver fibrosis have been accepted also by clinical guidelines. And there are several guidelines published clinically, and the European Federation for Ultrasound in Medicine and Biology has recently updated the guidelines for the non-invasive assessment of diffuse liver disease. These guidelines are freely available on the EFSUM website or the website of the journal, and are guidelines clinically oriented. The combi elasto that is now available on the Inaloca Arietta system is a combination between shear wave measurement and real-time tissue elastography. And also there is an attenuation index that evaluates the degree of liver steatosis. The shear wave measurement method is a point shear wave measurement technique available since a few years. And each measurement that we obtain using this system is the median value of effective shear wave velocity that is obtained from several push track sequences, after subtracting the noisy values. So the distribution of velocity is shown and presented as an histogram, and what is very important is that the percentage of effective measurements that is named is a reliability index, is shown on the screen as a VUSN. And this is very important because higher the VUSN, higher the reliability of the single measurement that we obtain. And the advice is to use a VUSN that is equal to or greater than 50%. We have performed a study using this method, the shear wave measurement method, in a large series of patients with chronic viral hepatitis, and transient elastography was used as the reference standard, because nowadays, at least in Europe, the liver biopsy is not used anymore in patients with chronic viral hepatitis due to the availability of very effective drugs for the treatment of these patients. And the main aim of this study was to find cutoff values for ruling in or ruling out significant liver fibrosis and liver cirrhosis, because these two are the most important endpoints in patients with chronic liver disease. And patients with liver cirrhosis should be followed up for complications related to the disease. Patients with significant fibrosis should be treated to avoid the progression of the fibrosis. In this study, we also looked at quality factors. One is the AQR divided by median value that should be less than or equal to 30%, and so we compared the measurements obtained using this quality criterion to measurements where the quality criterion was not fulfilled. And also at the reliability criterion that is suggested by the manufacturer, the VSN, the reliability index, higher than or equal to 50%. These are the results that we obtained. As you can see, when we compare the results to those of the FibroScan, the agreement between the two techniques was pretty high, with the NR of 0.77. And also the concordance between the shear wave measurement method and transient elastography method was higher for higher values of VSN, and the best performance was for values with a VSN equal to or higher than 50%. So this criterion that is suggested by the manufacturer should always be followed. And also we obtained, using the FibroScan as reference, the cutoff value for ruling in or ruling out significant fibrosis and liver cirrhosis. Strain imaging is a real-time tissue elastography technique, and the method displays the strain of a tissue as a color map in real time. I believe that you are familiar with the strain imaging of superficial organs. It can be used also for the liver, and usually using this technique, harder areas are displayed in blue and soft areas in red, intermediate area in green. And in the sample box, there's a mixture of color, and up to 256 gradation of colors are used. And based on several features, up to 10, using a multiple regression analysis, a liver fibrosis index has been derived for staging liver fibrosis. And in the past, the linear probe was used. Nowadays, the software is also available with a convex probe, and the penetration is improved significantly. What is the rationale of combining strain elastography with shear wave elastography? We know that using shear wave elastography, there are confounding factors, mainly related to congestion, necroinflammation, or jaundice. And studies performed in the past have shown that for strain elastography, the results are not affected by these confounding factors. The parameters that are obtained using the combi-elasto technique are, of course, the shear wave measurement, the velocity of the shear wave that is displayed either as meter per second or in kilopascal. and other parameters related to strain, the liver fibrosis index, the fibrosis index that is related to only fibrosis and is derived by the strain histogram and the velocity of the shear wave, and the inflammation index, named the A index, is the activity index. And there's also the possibility to quantify liver steatosis using the ATT. All these parameters are shown all together on the screen when we perform the measurements. So theoretically, all these parameters provided by Combi-Elasto are able to assess the fatty liver, hepatitis, viral hepatitis, acute phase, the fibrosis, and liver cirrhosis. The background for using the Combi-Elasto is based in several studies. I'm showing one of the latest studies performed, and is in patients with autoimmune hepatitis. Shear wave elastography with the transient elastography was used in this case, and strain elastography. And as you can see from the results, there was, after treatment, a decrease of the stiffness assessed using shear wave elastography, whereas the liver fibrosis index that is derived with the strain elastography was not affected by the decrease of inflammation. And there's another study, is a multi-center Japanese study in almost 400 patients. The gold standard was the histology, and the study was performed to derive the algorithm based on several features, combining the velocity obtained with shear wave measurements and strain features. And the fibrosis index and inflammation index were derived. And then assessing the stiffness and fibrosis of the liver, these parameters were able to distinguish between fibrosis and inflammation. Another important parameter that we may have now using the system is the quantification of liver steatosis using the ATT parameter. Is an estimate of the attenuation in decibel per centimeter per megahertz, and the software is based on a double frequencies that is read by the software of the equipment, and to eliminate using the double frequencies the effect of structures like small vessels or variation in brightness. And why is important to quantify liver steatosis? We know that non-alcoholic fatty liver disease is nowadays the most common liver disease worldwide. And this disease has no symptoms in the majority of cases. And NAFLD comprises a wide range of liver injury, from simple steatosis to steatohepatitis and liver cirrhosis, with the complication related to liver cirrhosis. And in these patients, could we consider liver biopsy the gold standard? We know that it is an invasive procedure with a risk of complication, is painful, is not well accepted by patients, but mainly in patients that have no symptoms and is NAFLD disease that affects 30–40% of the population. May we say to the patient, you have to undergo liver biopsy just to assess the steatosis, and it's not an ideal procedure for screening or for follow-up of the patient. And ultrasound is the imaging modality that is widely used in the general population for diagnostic purposes, for screening of NAFLD due to, we know it's non-invasive, no radiation is repeatable and has a low cost. So to have the possibility to assess with ultrasound in a single examination the morphology of the liver, the stiffness of the liver, to have information about the activity of the disease and quantification of the liver steatosis seems a real advance in the management of patients with chronic liver disease. Thank you.
Thank you very much for that overview of liver fibrosis and steatohepatitis. Are there any questions from the audience here? Yes, please.
Thank you, Professor. You taught me technical. I'm interested in this subject because it's easy to perform in Africa. My interest is when you say we no longer want to go by histopathology, then you say it's also painful. Then thereafter, I had my patient, I'm going to begin up because she's going to do fetus ablation. In matters of pain, fear, in matter of diagnosis standards, how do you write the notes out? Because after separated,
Using non-invasive methods, it has been shown that the accuracy in staging liver fibrosis, if we want to know liver fibrosis, is quite high. And so non-invasive methods can now substitute liver biopsy. Of course, biopsy should be performed for assessing other features that are not possible to assess using non-invasive methods, like in case of accumulation of substances into the liver, the ion deposits, and so on. But if our goal is to understand the stage of liver fibrosis, now we confidently may use the non-invasive methods alone.
Thank you. So now we've cured hepatitis B with vaccination. Hepatitis C, we've got drugs, but lucky for the doctors, we've now got non-alcoholic fatty liver disease to keep us in business. Is this right?
Yes, yes. And all the hepatologists now are switching to not viral hepatitis,
Yes.
non-alcoholic fatty liver disease. That is one of the most frequent liver pathology.
Yeah. Okay, so we're all still in business.
Yeah.
Thank you very much.
Welcome.
Okay, and now it gives me great pleasure to invite Dr. Fieg up from Germany, who's going to talk about the value of high-field open MRI and ultrasound image fusion for the detection of prostate cancer. Welcome.
Mr. Chairman, thank you very much for the introduction. Dear ladies and gentlemen, now a practical approach. I want to talk about the value of high-field open MRI and ultrasound image for fusion for the detection of prostate cancer. So the main objective of our study was to compare the overall cancer detection rates of an MRI ultrasound image fusion compared to the conventional trusted transrectal ultrasound fusion approach. So what is new with our approach? We used an open MRI system, a high-field system, and we did it in daily clinical routine practice. Disclosures. So our inclusion criteria. Men with elevated PSA or a suspicious finding on the digital rectal examinations underwent an MRI and prostate MRI and multiparametric prostate MRI in my practice. And we scored 237 men with a pirate score of 3 or higher, and these men were included in our study. So when the pirate score was 2 or less, they were not included. And in these men, we identified 372 index lesions, and we evaluated them. 88 men were biopsy naive, and 149 men had at least one negative biopsy prior to the MP MRI. And median age was 67, so the estimated lifetime expectancy was in the range of 10 to 15 years, which is important for clinical decision making. Mean PSA was 7.5 nanograms per milliliter. And I have to say it's a retrospective and non-randomized trial. We used this scanner, the Hitachi Oasis, a 1.2 Tesla high field open MRI scanner with a vertical magnet and a gradient strength of 33 millitesla per meter and a slew rate of 100 Tesla per meter per second. For the prostate examination, we used a dedicated 6-channel phased array body coil, and no endorectal coil was used because of acceptance of the patients and comfort. In Germany, in a daily clinical routine practice, patients do not accept endorectal coils. And this is our examination protocol. It lasts of 6 sequences, and it consists of 6 sequences, and every sequence lasts in the range of 4 to 5 minutes. First, we started with the T1 weighted fast spin echo sequence of the whole pelvis for lymph node detection and for bone metastases. And then 3 T2 weighted images followed. One was a 3D sequence, an iso-FOC sequence with a near isotropic resolution. This sequence is important for our fusion and for the software we use with that. The T2 2D sequences have a slice thickness of 3.5 millimeters. This is a little bit lower than recommended from the German Röntgen Society. The German Röntgen Society recommends 3 millimeters. And resolution was in the range of 0.8 or 0.9 millimeter, which is even a little bit lower than recommended. It's recommended to use 0.7. We have to use these parameters to make a compromise. On the one hand, resolution, signal-to-noise ratio. On the other hand, patient comfort, potentially motion artifacts, and examination time. And then a diffusion-weighted image, EP sequence follows with a slice thickness of 3.5 millimeters 2. We used the highest value of the highest B value we used was 800. And finally, a T1 weighted gradient echo sequence for dynamic contrast enhancement followed slice thickness 3.5 millimeter 2. The time resolution of this sequence is in the range of 15 seconds. The German Röntgen Society recommends in the range of 12. We always scored with the pirate score. We started with version 1 in 14, and after 2015 we used the version 2. And on the right side, the well-known theme is shown, which we use for the structured image interpretation and for the communication to our urologist. These are the ultrasound platforms. We used 2 high-end platforms from Hitachi, the Priorus first and afterwards the Arietta. And we used the biplane probes. My urologist who did the Probe sampling for me is well trained in using biplane probes, so he wanted to do it with that. There are also one plane or end-fire probes available. The MRI 3D data set is transformed to the platform and the real-time virtual sonography software. I have to identify on the MRI dataset the lesion. I identified it with this spherical marker, and after that the fusion could start, and when the fusion had finished, the spherical marker will appear on the real-time ultrasound image, and then it is very easy to get the probe score. Here you can see how we do it. On the left side, my colleague, Dr. Moyer, the urologist, he always joined me, and he did the core sampling, and I assisted him. He came to our practice, so it's a joint venture, a special new aspect in Germany. The model is rigid fusion according to anatomical landmarks. So we marked maybe the bladder neck or cysts, and then fusion started. So no prostate contouring was necessary, and it was a transrectal approach. In every session, we sampled 2 cores for each lesion, and then 12 cores for the truss biopsy in the same session. And these are our results. We identified 372 lesions overall. We scored 271 as Pirates 4. And in 122 of these lesions, cancer was detected. So cancer detection rate for Pirates 4 was 45%. With Pirates 5, the numbers are higher, as expected. So here we have 40 patients of 54 who had cancer at all. So cancer detection rate was in the range of 74%. So I can say that the cancer detection rate for any cancer, when we look at the lesions, is in the range of 50%, 162 of 325 lesions. When we look at significant cancer, and we said significant cancer is when cancer was found with Gleason 3+4 or more. We did not take into account core size or calculated nodule size. So when we took this into account, 87 of 325 lesions had significant cancer. So this was 27% of all sampled cores. When we look not at lesions, but when we look at MIN, so we detected in 115 of the 337 MIN cancer, so 50% at all. When we look at the truss biopsy alone detected only in 101 men cancer, so 25%. And we have to take into account my urologist was not blinded. He knew the position of the targeted lesions, and then afterwards he did the truss biopsy. In future, we have to look at this point. Truss alone was positive in 21 of 337 men, and MRI fusion was negative, so we missed cancer. We will look for that in future. So what does the literature say, and what does other colleagues say to this? Valerio published a systematic review in European Urology in 2015. And in this review, he looked at 14 studies, and I will focus on these 6 studies. So the sample size, that means the size of the cohort, sometimes lesions, sometimes patients, was a little bit different from our approach. It was an inhomogeneous cohort 2. Some patients had previous biopsy, some not. And magnetic field strength different from our study because the colleagues always used a tunnel system. sometimes 1.5, sometimes 3 Tesla systems. And what about their results? Let's look at the detection rate of clinical significant cancer. It differs from 13 to 50%. Remember, our results are 27. And the cancer detection rate of any cancer differs from 35 to 55%. We are in the range of 50%. So let's look at some examples. A 74-year-old man slightly raised PSA of 4.8, one prior negative biopsy. So on the T2 weighted image in the mid-gland, it's easily to detect. You can see here this homogeneous lesion right on the left side of the peripheral zone. I scored it as Pirates 4. It was less than 1 centimeter in diameter. The diffusion is markedly restricted, and the ADC map showed a hyperintense signal. So this is Pirates 4-2. And the contrast medium showed a focal and earlier contrast enhancement. So DCE was positive. Here right in the middle, typical BPH nodule enhancement. Pathology showed a Gleason 8 cancer. Oh, PSA 4.8 at a Gleason 8 cancer. Second example. T2 weighted image, 77-year-old patient, rise PSA 6.4, biopsy naive. The T2 weighted images, mid-gland portion on the peripheral zone, there is a lesion, yes, but it's maybe triangular shape, maybe wedge-shaped. Pirates 2, I scored it as Pirates 3 because of these very low signal point at the rim of the lesion. Diffusion and ADC map has an artifact because of the air in the bowl. No real restricted diffusion, I assumed. Maybe a little bit reduced ADC, maybe an artifact. I didn't really know. I said, okay, it's 3. And contrast enhancement, not really, a little bit. So maybe negative. We did the biopsy, and it was in the first core Gleason 4+3 cancer, and in the second core Gleason 6 cancer. We missed it. And the third example, my last patient, 69-year-old, rise PSA of 9.3. It rised in the last 2 years especially, and he had 2 prior negative biopsies, 2 and 1 year ago, and I can show you why the trust biopsy was negative. So here, right at the apex, in the anterior fibromuscular stroma, there's an ill-defined hyperintense lesion in the diameter of 1.4 centimeters. So clear case for me, Pirates 4, diffusion markedly restricted, maybe a little bit rounded, maybe a little bit of bulging of the prostate capsule. I didn't say it was extracapsular or extraprostatic extension. And ADC map showed a hyperintense signal and focal earlier enhancement on the DCE images, a little bit rounded like a BPH nodule. And proven cancer 3+4. And these are the limitations of our study. So we only defined clinical significant cancer by the Gleason score. We did not take into account surrogate markers like core length or estimated volumes of tumors. Our study included a heterogeneous population. Some had prior biopsies, some not. And we did no comparison with prostatectomy specimens. Yeah, it was a rigid fusion model approach, so we have to take into account there are errors, sampling errors due to the deformation caused by the force of the probe and changes in the shape of the probe, and there will be a sampling error in the range of 1, 2, 3, maybe 4 millimeters. And finally, my urologist could not blind out himself because he knows the former targeted lesion position. Conclusions. The overall cancer detection rate of an MRI transfusion biopsy done with a high-field open MRI are very comparable with previous published data. And the cancer detection rate in our approach was, for the fusion biopsy, was 60% higher than for the truss biopsy alone. And we are really more efficient. With fusion biopsy, we need less than 1/6 of pores in comparison to the truss biopsy. And I state fusion biopsy misses only an insignificant number of significant cancer. But we have to confirm that in future. But further improvements in resolution and signal-to-noise ratio are necessary. And with this image, I want to thank you for your attention. The Cathedral of Paderborn, built on a former palace of Carolus Magnus. Thank you very much.
Thank you very much for a very comprehensive review of the capabilities of fusion imaging there. Do we have a question from the audience? Can I ask a couple of questions? You've mentioned the deformity with the transrectal probe. Is there a learning curve for this to make it a thing? And also, how confident are you with the fusion imaging? Are you very confident that you've got it in the right place each time?
Yes.
Yeah.
When we can...
Speak on the microphone.
Oh, yeah.
Yeah.
Sorry. Yes, I'm really confident when I saw typical fusion-capable lesions like the bladder neck or cysts, then I'm really confident. Sometimes, it's very difficult. Yeah? So I think we have an error of 3 to 4 millimeters overall.
Okay. And then with the deformity, how do you train to not to deform? Do you have to be very careful?
Yeah. Yes, you have to be very careful, especially in the apex and in the anterior portions. But my urologist is well trained now.
Well done.
Because he knows that problem in the past. And yeah, you need 20 to 30 patients to cover with that.
Okay. Very interesting. Thank you. Oh, there's one more question, sir.
Thank you. I'd like to know if the patient's men are passed through the rectal probes. I will tell them the industry, how I will convince them to accept the rectal probes. Sorry, I didn't understand. Rectal probes, you said the men of our Jesus. If I'm understanding the question. And the rectal probes.
I think what he's asking is, how are you going to get your patients to be more accepting of endorectal probes?
The probes?
Yes, the coils, yeah.
The probes we need, so
Yeah.
the coils we need, so that's clear.
Yeah.
But endorectal coil, no chance. In
Okay,
Germany, no chance.
Okay.
For a practical approach, in a daily clinical routine practice, no chance.
Okay. All right, I'm going to thank all the speakers for keeping to time and delivering excellent lectures, and I thank the audience for their attention and staying to the very end. And a round of applause for everyone as I call this to end.